Welcome to your ultimate guide to therapeutic drug monitoring. In this video, we break down the essential TDM procedures for 4 critical medications: Amikacin, Gentamicin, Vancomycin and Tacrolimus. Whether you're a healthcare professional, student, or curious mind, you'll learn the following. 1. When and why monitoring is crucial. 2. Proper timing of sample collection. 3. Interpretation of levels and dose adjustments. And 4. Tips for avoiding toxicity and maximizing therapeutic outcomes. Let's make drug therapy safer and smarter, starting now. The objectives of this video include the following. 1. To understand rationale for therapeutic drug monitoring, abbreviated as TDM. 2. To review peak and trough timing for key drugs. 3. To discuss target serum concentrations. 4. To outline frequency of monitoring. And 5. To emphasize best practices in documentation and patient safety. We will now focus on the rationale for monitoring. Amikacin, an aminoglycoside antibiotic, has a narrow therapeutic window. TDM ensures efficacy, that is, bacterial kill rate is concentration dependent, and prevents nephrotoxicity and ototoxicity. In pharmacotherapy with aminoglycosides, 2 dosing strategies are used, namely, 1. Multiple daily dosing, abbreviated as MDD, and 2. Extended interval dosing, abbreviated as EID. Next we will consider the sampling timing. For peak level, draw the blood sample 30 minutes after the end of a 30 to 60 minute IV infusion. If amikacin is given IM, draw the blood sample 60 to 90 minutes post-dose. For the trough level, draw the blood sample within 30 minutes before the next scheduled dose. In the case of extended interval dosing, use a single random level at 6 to 14 hours post-dose. We will now focus on the target concentrations. In the case of multiple daily dosing, the recommended peak levels should be 15 to 30 micrograms per milliliter. The recommended trough levels should be below 5 micrograms per milliliter, ideally below 2 micrograms per milliliter for lower toxicity risk. In the case of extended interval dosing, otherwise known as once daily dosing, do not use peak or trough levels. Instead, draw a single random level at 6 to 14 hours post-dose and apply Hartford nomogram to determine dosing interval, that is, 24 to 48 hours. We will now shift gears to monitoring frequency. The initial levels should be obtained after the 3rd dose, after achieving steady state. Reassess it every 2 to 3 days during therapy. Monitor it more frequently if 1. Renal function is unstable, e.g., creatinine rising. 2. Patient is critically ill, elderly, or on concurrent nephrotoxic agents. And 3. If significant fluid shifts or sepsis are present. Next we will focus on the Gentamicin TDM protocol. Let's begin with the rationale for monitoring. Gentamicin has concentration-dependent bactericidal activity and a narrow therapeutic index. Proper monitoring prevents nephrotoxicity and ototoxicity. Regarding sampling timing, samples for peak levels should be drawn 30 minutes after the end of a 30 to 60 minute IV infusion. Samples for the trough levels should be drawn within 30 minutes before the next dose. We will now look at the target concentrations. In the case of multiple daily dosing, we should target peak concentrations of 5 to 8 micrograms per milliliter for most infections and up to 10 micrograms per milliliter for severe infections, e.g., pneumonia or endocarditis. Trough should be below 2 micrograms per milliliter, ideally below 1 microgram per milliliter in the case of extended interval dosing, also known as once daily dosing. We should measure single random levels 6 to 14 hours post-dose. We recommend you apply nomogram, e.g., the Hartford nomogram, to determine the next dosing interval. Regarding monitoring frequency, first TDM sample should be drawn after the third gentamicin dose. Repeat every 3 to 4 days or with the following scenarios. 1. Alterations in renal function. 2. Prolonged therapy, lasting longer than 5 to 7 days. And 3. In the elderly or critically ill patients, perform daily levels. We will now look at a vancomycin overview. It is a glycopeptide antibiotic which exhibits a time-dependent killing in which a UC to MIC ratio-based monitoring is preferred. It has a narrow therapeutic window. Next we will look at its rationale for monitoring. Vancomycin is used to treat serious gram-positive infections including MRSA. Trough-based monitoring is used to maintain effective drug levels and minimize nephrotoxicity. Regarding sampling timing, only trough levels are routinely measured. Peak levels no longer recommended. The sample should be drawn within 30 minutes prior to the fourth dose, that is a steady-state trough. Regarding the target trough concentrations, 1. In the case serious infections, e.g., bacteremia, pneumonia, osteomyelitis, or endocarditis, it is between 15 and 20 micrograms per milliliter. 2. In the case of mild to moderate infections, e.g., skin, soft tissue infections, it is between 10 and 15 micrograms per milliliter. An alternative, or preferred strategy is the AUC-based monitoring. Remember to target an AUC to MIC ratio of 400 to 600, assuming MIC is equal to 1 microgram per milliliter. It requires 2 timed vancomycin levels, peak and trough, and software or calculator to estimate AUC. Regarding the monitoring frequency, it should first be done at steady state, just before the fourth dose. Recheck it every 2 to 3 days during therapy, or 1. With changes in renal function. 2. When the dose or frequency is adjusted. And 3. If therapy extends beyond 5 to 7 days regarding special considerations. Avoid troughs above 20 micrograms per milliliter due to increased nephrotoxicity risk. Monitor renal function, that is serum creatinine, or urine output, at least every 48 hours in inpatients. Next we will progress to the Tacrolimus TDM protocol. Regarding rationale for monitoring, Tacrolimus is an immunosuppressant with a narrow therapeutic range and high interindividual variability. TDM prevents organ rejection and toxicity, that is nephrotoxicity, and neurotoxicity. Next we will look at sampling timing and targets. Measure trough concentration. Draw the blood sample within 30 minutes before the next oral dose, ideally just before morning dose. Target trough concentrations vary by transplant type and time post-transplant. In the case of liver transplant, at 0 to 3 months post-transplant, target 8 to 12 nanograms per milliliter. In the case of kidney transplant, at 0 to 3 months post-transplant, target 8 to 12 nanograms per milliliter. In the case of heart transplant, at 0 to 3 months post-transplant, target 10 to 15 nanograms per milliliter. In the case of liver transplant, beyond 3 months post-transplant, target 5 to 10 nanograms per milliliter. In the case of kidney transplant, beyond 3 months post-transplant, target 5 to 10 nanograms per milliliter. In the case of heart transplant, beyond 3 months post-transplant, target 5 to 10 nanograms per milliliter. Next we will look at monitoring frequency. During the initial phase, that is 0 to 4 weeks post-transplant, monitor daily to every 2 days. In case of dose adjustments or interactions, recheck 2 to 3 days after change. During the maintenance phase, 1. Monitor weekly to monthly, depending on stability. 2. Adjust frequency based on the following: renal or liver dysfunction, interacting medications, or non-adherence. Increase frequency of monitoring if need arises. We will now briefly look at a few special considerations. Tacrolimus is metabolized by CYP3A4 or 5, subject to many drug interactions, e.g., azole antifungals, macrolides, and calcium channel blockers. We should therefore monitor renal and hepatic function closely. Blood samples should be drawn consistently at the same time each day. Next we will look at general notes for all drugs. Regarding documentation, 1. Always record exact infusion time, dose administered, blood draw time, and route of administration. 2. Regarding renal function, monitor serum creatinine and urine output regularly for nephrotoxic agents. 3. Regarding sample handling, use proper tubes, usually EDTA or plain tubes for tacrolimus. Transport to lab promptly. Follow cold chain if needed, especially for tacrolimus whole blood levels. 4. Regarding patient education, inform patients of the timing and importance of blood sampling. Emphasize adherence to scheduled dosing times for accurate monitoring. And now in summary: 1. Accurate timing and documentation critical to TDM. 2. We should individualize targets based on infection, organ transplant, and patient status. 3. Frequent reassessment prevents toxicity and improves outcomes. And 4. AUC-based vancomycin monitoring increasingly preferred. Thank you very much for your undivided attention. And that wraps up our deep dive into therapeutic drug monitoring of aminoglycosides, vancomycin, and tacrolimus. These powerful drugs can be life-saving, but only when monitored with precision and care. If you found this video helpful, don't forget to like, subscribe, and hit the bell so you never miss a dose of insight. Got questions or want us to cover another tricky medication? Drop a comment below. I would love to hear from you. Until next time, stay curious, stay safe, and keep learning.